Good afternoon, everyone. This is Professor Irene Dunham, and this is just going to be a short weekly review. It's been an exciting week. So, this week, according to your syllabus, you had um, two chapters. Chapter 10, Nursing Care of Women with Complications at the Birth, and then you have chapter 12, The Term Newborn. Now, let me let me suggest that you do a couple things when you're doing all these complications after birth. So get a piece of paper out and put 1, 2, 3, 4, 5 columns. Okay. And then you'll have going down, you'll have the disorder, the complication. Okay. On top, the first column is going to be the complication. Okay, that's called disorder. So the first column is going to be titled disorder. The second column, put pathophysiology. The third column, signs and symptoms. And the fourth column, treatment. And the last column, nursing management. So how we're going to group this is into the different categories. Now, how I like you to do is the first one is called shock. So shock, under pathophysiology, what would you think shock would be? Well, it's a condition in which the cardiovascular system fails to provide what? Essential oxygen and nutrients to the cells. So there's different types of shock. You have cardiogenic, and that's caused by a pulmonary embolism or an anemia, which a lot of women are. Hypertension, or any signs of cardiac disorders that they may have had. The next category under shock would be hypovolemic shock, and that's caused by postpartum hemorrhage or maybe a blood clotting disorder. The next shock is anaphylactic, and you know what that is. That's caused by an allergic response. And then you have septic, which is caused by what? An infection. Okay, so under signs and symptoms of a person in shock, you would have tachycardia. Highlight that, please. Then you have cold, clammy skin, pale. Maybe you have some fingernails and your lips a little bluish, right? Okay. Nausea, vomiting, dizziness or fainting, and changes in their mental status. All right. And they may have some enlarged pupils. You can put that in there. Okay. Then under treatment, well, you got to stop the blood loss. Give IV fluids to replace fluids. Blood transfusion to replace erythrocytes. Give oxygen to increase saturation, right, in the remaining blood cells. I'm going to place an indwelling catheter. I have to know if the kidneys are functioning. So I want to assess her urine output and then massage the uterus and administer drugs to contract the uterus. Okay. And so you got nursing management, assess vital signs every 15 minutes, observe for signs of shock. Okay, gotta continue. She might get worse on you. Especially if the kidneys start to get involved and they decrease the urinary output. Assess her lochia, folks. Yeah. Now, she just delivered, so she would have lochia rubra, but she might be passing large clots. And then look for any kind of bleeding under the skin, such as petechiae. And the biggest one I came across one time was bleeding from the venipuncture sites. My patient actually bled out from her IV catheter, and she went into DIC, disseminated coagulation. So it's not good. Allegoria. And then you always want to keep abreast of those perineal pads and see how much she is bleeding out. I've always kept my pads. Okay. So that's shock in a nutshell. The next category down, okay, go down one. Now you're going to have a new one called hemorrhage. So under the column disorder, put hemorrhage. Now, hemorrhage. So we know for vaginal delivery, hemorrhage is blood loss greater than 500 mLs at the vaginal, or is greater than 1,000 or more for a C-section. Again, there's two types of hemorrhage, and I refer to as early and then late. So early hemorrhage is within the first 24 hours, and late would be after 24 hours. And it doesn't go for 12 weeks, it goes for 6 weeks after birth. And that can be caused by retention of pieces of the placenta or subinvolution of the uterus. What are your signs and symptoms? A sudden severe headache, seizure with no previous history of a seizure, weakness in arm or leg. How about nausea, vomiting? Yeah. Decreased alertness. Okay. She goes in and out on you. Lethargy. Changes in vision or tingling or numbness. What's your treatment? Well, oxytocin or your synthetic version, which would be Pitocin. Methogen, prostaglandins that would what? Contract the uterus. So a contracted uterus will expel the fragments. Well, we want to get that uterus cleaned out. So you might, if she has fragments, she might need more of a surgery intervention. Okay, so how are you going to handle, maybe she's going to go home and you worry about her. Teach the patient what to expect, like the changes in lochia. Have the patient report persistent red bleeding. And if lochia goes back a color, like it goes and progresses to alba, and then goes back to rubra, that's an indication that something's just not right. Okay, there's placenta probably there. Got to get back to the hospital. She probably needs a surgical intervention. Okay, so my next complication would be subinvolution, which is what? Is a slower than expected return of the uterus to its non-pregnant condition. It can be caused by infection or retained placenta fragments that are left in the uterus. What are your signs and symptoms? Well, fundal height is greater than expected for the amount of time after birth. So remember, where should the uterus be right after birth? Is at the level of the umbilicus and its midline. Excuse me. If she has persistent or lochia rubra or a slow progression during the 3 phases, then something's not right. Oh, excuse me. Okay, so treatment. All right, correct the cause of subinvolution. Methogen again maintains it's good to maintain a firm uterine contraction. Now, if your patient is hyper HYPER tension, means high blood pressure, you don't get methogen. Now, again, surgical intervention may be necessary. Nursing management, well, you're going to teach your patient to report a fever, persistent pain, persistent red lochia, and return of bleeding after it has changed or foul odor. To teach the woman to palpate the fundus. Okay, your next disorder is going to be thromboembolic disorders. What happens under pathophysiology? You got a blood clot there. It's caused by venous stasis from having made the legs in stirrups, and she's been, basically maybe laying in bed. Can be also caused by blood vessel injury during a C-section. And there's 3 types. You have your SVT, which is superficial. You have your DVT, and you have your PE. Okay, so your treatment for a thrombo could be medication. You want to treat your DVT with maybe an anticoagulant. Elevate the legs, and an analgesic. Maybe she needs some analgesia. Okay, nursing management. Always observe for signs of a venous thrombus. And LPNs can work on the mother-baby unit, and so you would need to know all this to be able to pick up on it. And really, guys, you'll be nurses, and you could be on a med surg floor, and you have to always be on the outlook for anybody having a thromboembolic disorder. Okay, anybody. So you have to be very careful with your patients and always be on alert. Okay, what do we do even on the med surg floor? We get our patients up out of bed early. All right, our surgical patients, even our cardiac patients. We used to keep them in bed a lot longer, and now studies have shown to get them up and moving, and that really, really helps with the problems of a blood clot. Because what happens when a DVT is in the calf of the leg, right? So you have this little blood clot sitting in there, and what happens eventually, that gets dislodged, okay, and it moves. And when it moves, it's going to move up the body, right? And it's going to go right up into the pulmonary artery. And when it does that, it becomes a pulmonary emboli. Okay. Patients they can't breathe, they have chest pain, and they get rapid breathing because, sure, they're panicking. Okay, yeah, it's painful to get a PE. Okay, the next disorder we want to hit upon is infection. So, puerperal infections or postpartum infections, they do happen. You can get sepsis after a birth, okay, and a fever, and in the big one we see a lot of is endometritis. That's inside the uterus, and so mom gets, she has a prolonged drainage. Maybe if she had a C-section, the surgical incision is starting to come apart. Even with staples, I've seen this where the purulent drainage was coming right through. The skin was starting to dehisce, open up, and the drainage was starting to come out. Okay, and it had a really foul smell to it, and so that's after a C-section. And that's why we have to be very, very careful to have sterile technique in the OR, and then sterile too when we're doing it. The practitioner has to do an episiotomy. So we went over, when you look at episiotomy, use that mnemonic REEDA, REEDA. And basically what that is, R is for redness, first E is edema, the second E is for ecchymosis or bruising. Then you have drainage, and then you have approximation. Okay. All right. Now treatment, antibiotics. Got an infection, you got to get it cleared up. So, and then also teach mom and everybody to use proper hand hygiene. Okay. Now for the episiotomy, we want to keep it clean, 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 clean. So we're going to have the peri bottle for every time after she urinates or she has a bowel movement. And then we have the cis baths. They really do work very nicely. She can go home and continue with the cis baths in her own bathroom. Okay, the next complication we're going to talk about is mastitis. Now, mastitis is an infection of the breast. Okay, it occurs, 2 to 3 days after giving birth. It occurs when maybe there's a bug from the skin, or it could be the infant's mouth, and sometimes bugs can enter small cracks in the nipples or the areola. That's why you want to make sure that your the infant has a good hold on mom's entire areola. If she has some breast engorgement, sometimes they can get mastitis. Okay. Inadequate emptying of milk can cause mastitis. But the main cause usually, I can tell you, is those sore nipples. And that just comes from improper latching on. That's why every postpartum nurse must watch how the baby sucks. Okay. All right. And then we have signs and symptoms. Redness and heat in the breast. It gets very, very uncomfortable. Tenderness. I called it painful. And then you have edema and heaviness in the breast. And I have seen where the breast gets so engorged that it also goes under the armpit into the tail of Spence, and that becomes very hot and sore too. What's your treatment? Is antibiotics, um, and then mild pain reliever sometimes, and then you want to make sure she empties her breast, okay? And maybe take a little bit of the milk after she gets done breastfeeding and just put it over the nipple. And a lot of times too, you know what's really great too is I always tell them, mom, just be in a bedroom um, with no bra, nobody around, just let the nipples air dry, and that really works very, very well. Okay, the next complication we're going to discuss is called mood disorders. Mood disorders, and they're just, you know, emotions that maybe will change how the person is viewing life. Um, and it could be also from fluctuation levels, hormone levels. And another problem too could be causing it. She's overwhelmed. You know, you have baby blues, you have depression that shows its nasty phase about 4 weeks after delivery, and then you have postpartum psychosis. So, what are some signs and symptoms that you have to be kind of looking at? Well, a lack of enjoyment in life, disinterest in others, feeling of inadequacy, disturbed sleep, and loss of mental concentration. And so, what are you going to do? Maybe she'll have some psychotherapy, some antidepressants, and light therapy, exercise, and then counseling. Okay. So, what's your nursing management? Someone who has a mood disorder. Well, you want to maybe get social services that can be available to the patient and screen the patient for depression. I'm going to tell you, everyone that leaves the hospital we do it the depression scale. Okay. Then you have postpartum psychosis. Well, that's life-threatening and it's very dangerous thoughts that need medical intervention. Okay, she could be thinking of suicide herself or infanticide. So what happens? It can be that they have a weak support system. They may have unplanned pregnancy. They may have severe financial problems. It happens. Or she might have, I remember the history of depression when she first came to you. She said if on the first visit that you interviewed your patient and she said she had a history of depression, that would have been a red flag. Okay. Everybody, they go through pregnancy, you have complications, you may have a preemie baby, things you just didn't plan for, and it causes more financial burden to you and your family. Difficulty bonding. What happens is some signs and symptoms would be difficulty bonding with your baby. And it's to a fear that you're not a good mom. So you withdraw from your family. You have a loss of appetite, inability to sleep, overwhelming fatigue, intense irritability, and we already talked about feeling of unworthiness, restless, severe anxiety, so many panic attacks too. And sometimes, like I said before, they think they hear voices. And it has been said that a lot to do with the history of bipolar disorder. When if they had that before they got pregnant, they're going to be more prone to this. And then they hear voices in their head, and the voices tell them that they're not worthy to be this mother. Like she can't be a good mom. Maybe, she never had bonding with her own mom. or her own dad. And so she doesn't know how to be a mom. She was never taught. People that end up in foster care and on, they lose some things through the years. And so these are kind of women that are more set up to. Okay, so treatment, you're going to maybe have to be put in the hospital for a while. Psychiatric counseling is recommended. We want them to express their feelings. We want to, and maybe get them on some good antidepressant therapy. Okay. What's your nursing management of this kind of patient? Well, assist the woman in planning her daily activities. Because don't forget, they need help getting, back on track. Maybe exercise, nutrition, and sleep. Those are the key components. Recommend support groups. Yeah, have her go out and see other women that have this disorder. Sometimes when you have a problem like this, you feel that you're the only one out there, but you're not. Okay, and then she had any friends before delivery? Well, get reconnected. All right. So what happens is that if we can recognize the problem of depression from that first visit, then we're more in tune then to follow up even closer with these kind of patients. The main thing is to keep the baby safe. Okay, so those were the complications that we went over the other day in that chapter. Okay, let's see here. And that was chapter 10, nursing care of women with complications after birth. Okay, so we went ahead and did the complications in kind of a little nutshell, but it works. Just make your different columns. Remember, first column would be disorder. The second column would be what? What causes the pathophysiology? The third column would be your signs and symptoms. The fourth column is treatment. And you always want to know the nursing management. Because that's what a lot of test questions are going to ask you. They give you the scenario, but you got to know about it in order that you know what the nursing management treatment. Okay, excuse me. Okay, so I want to do a little case study, and then we'll go over the answers so that you have them. But I'm going to point out as I read the case study to you, what's the important parts? Okay, what is this all about? Okay, all right, so here you go. I have a case study. I have a Janelle, and she is a 40-year-old gravida 6, para 5. Now, she gave birth to a 9-pound healthy male infant, born a normal spontaneous delivery 3 hours ago. Okay, so I have a grand multiparous, don't I? She's a gravida 6, okay? And that's what it is, gravida and para. And so now she had a 9-pound healthy boy. 9 pounds. What kind of a baby is that? That's called a macrosomic baby. So it's a big baby. So big babies require a big uterus to live in, right? So are you not thinking already? I'm thinking. Overdistended, enlarged uterus. It's going to set her up for a hemorrhage. Okay. Now, she had no medical problems, which is a good thing. Her pregnancy history was normal. Yay. Her labor course was normal. Great. She didn't have a prolonged labor. Nope. She just progressed as she's supposed to. Wonderful. Although her membranes did rupture for 24 hours before delivery. We're still in that 24-hour mark, but we're getting close to it because it said ruptured for 24 hours before delivery. So she could run a little temperature. You see how I'm thinking? Okay. Then she had no lacerations at delivery. Great. Because sometimes with big babies, they can cause mom to have a laceration in the peritoneal. Now, her vital signs are temperature is 99.6. Okay. little elevation, but not bad. Her pulse is 118. Now that's what I circle when I'm looking at a case study. 118. That's hot because after delivery, it's very common for a mom to have bradycardia. So this is on the high side. Again, let's see, that's tachycardia. So let's keep reading. Blood pressure 120/70. Okay, and respirations are 20. Great. Now she has an IV of lactated ringers, and you have 1,000 cc bag or ml bag with 20 units of oxytocin. That's what normal. We usually put 20 units in a 1,000 ml bag of LR after delivery because we want to keep contracting that uterus. Do we not? Yes. Okay. So what risk factors does Janelle have for postpartum hemorrhage? Well, what do you think? Okay, put your thinking caps on. So first of all, she's a multiparous. Okay, this is her what? She's a gravid of 6, and she's para 6 now because she had a delivery. Okay, and so that means that uterus has been stretched out quite a bit. Okay, all right. She had a large infant. She had a 9-pound baby boy. Again, I'm thinking the uterus overdistended. She has an infection. She has a slight temperature, but she was really on that rupture of 24 hours. So she could have another risk factor for an infection called chorioamnionitis. And so because of the slight temperature in the ruptured membranes of 24 hours. Okay. So we talked about so those are her risk factors. So we talked about the overdistension of the uterus by a large infant, which makes the rapid involution need to prevent postpartum hemorrhage more difficult. The uterus is going to be slower to contract after delivery, even with Pitocin, because it's been overstretched. Okay, so it involutes, but at a slower pace. Okay. So she could have an intrauterine infection, and we talked about chorioamnionitis, and that also would decrease the uterine contraction effectiveness. Okay, that means the uterus will contract slow. So she's got a couple things that's going to make the uterus contract slow. And then she's quite a big lady. I think her BMI is 36. So she's quite, she's obese. And that also increased the risk of postpartum hemorrhage. Okay, so that was your risk factors. Now, question 2 is the nurse performs an assessment of Janelle with the following additional findings. Okay, so now you're doing more of an assessment. So her uterine fundus is now, you feel it, about 4 centimeters above the umbilicus. And now is deviated to the right side. Okay, that's not good. It is not firm, and a large amount of vaginal bleeding and blood clots are noted, saturating the obstetrical pad. Okay, so what is the nursing priority in this situation? Okay, what do you think? Well, first of all, you firmly massage the uterine fundus. I'm going to make this lady void. Okay, her uterus is way above the umbilicus. It's like 4 centimeters above. That's way above. It should be at the level of the umbilicus, and it's over to what? It's over to the right. Okay, so remember what I said, the first thing you were going to do is you're going to have her empty her bladder. I want to get the uterus back to midline and at the umbilicus. Okay. And then if she can void on the bedpan, what are you going to do? Well, you can catheterize her if you have to. You have to, because you can't have it bleeding. Okay. So those are what I would do in this situation. And so my rationale is the most common reason for postpartum hemorrhage is uterine atony or atony, A-T-O-N-Y. Let me say that again. The most common reason for postpartum hemorrhage is uterine atony or atony. Is the uterus without tone. The worst thing that can happen. Okay. And so sometimes the uterus is often distended because and deviated because of a full bladder. Now, fundal massage and emptying of the bladder can help the uterus contract efficiently. So I would empty the bladder, catheterize if I had to. Okay, but I always offer the bedpan first because nurses, we always do the least invasive. So offering her a bedpan. But if she's probably bleeding and you put her on a bedpan, you hope and pray and you put a little water over her and try to get her to void. If she doesn't void, guys, you got to take her off the bedpan and get that done and get it catheterized, get the bladder down, and at the same time I'm massaging the fundus. Okay. And then you can call the provider if you want to evaluate and treat the patient promptly if essential. Okay. All right. So what's number 3 now? Question number 3. What etiologies other than uterine atony or tony could be contributing to this postpartum hemorrhage? Well, we kind of talked about that a little bit, and that could be retained placenta fragments. Yeah, could be. Yeah. Unrecognized pelvic lacerations. She could have it in the vagina. She could have a way up too. She could have a cervical laceration, or she could have a clotting disorder. So any of those etiologies could be contributing to a postpartum hemorrhage. So that's what you got to constantly think about. Okay. So let's see the next question. The physician evaluates Janelle and finds no lacerations and orders Hemorrhage, a 250 microgram IM. So why is this drug ordered? Okay. Well, he orders the Hemorrhage to increase uterine contractions, to what? To decrease bleeding. Yes. Okay. And the Hemorrhage is a prostaglandin F2 medication. So it's used as an extra treatment to the IV oxytocin or Pitocin to what? Make her contract. Okay. My next question in my case study that I know you have your thinking caps on is what are the side effects associated with the use of Hemorrhage? I'll let you think about that for just a second. And if you have to, look it up. That's the way you remember it. And some side effects would be nausea, vomiting, and diarrhea. Okay. Now, because these side effects are reported to occur in more than half of the patients, many physicians will order anti-diarrhea medicine, like, Imodium, and anti-vomiting medications along with Hemorrhage. That's pretty strong. Now, Hemorrhage is really strong. And so we don't use it unless we have to. But in this case, because she's hemorrhaging and you already have a strong prostaglandin infusing, that's the Pitocin, you got to go with something strong. Okay. And let's see, we have one more question. So these are kind of questions that you would see on maybe NCLEX one day. Yeah. So what are the ongoing nursing assessment and education needed with Janelle? Okay. So what are the ongoing nursing assessment? Well, I would include 1, vital signs, blood pressure, heart rate, pulse oximetry, respirations, temperature, abdominal palpation of uterine tone, always. Where's the uterus? What position is the uterus in? I'm also going to check the bladder. I'm also going to check her lochia and make sure she's voiding. Okay. And then, I also measure, if my patient goes in a bedpan, I'll measure each urine output. Okay. So you have one of those white hats. They look like a hat. You put them in the toilet. You offer your patient a bedpan, and she goes to the bathroom. You take the bedpan into the bathroom. You pour that urine into the hat. So you measure. Then you want to do pericare every time she goes to the bathroom. All right. And then I'm going to keep a close eye on intake. Keep an eye on how much fluid she takes in, how many glasses of water she's drinking, or coffee. Maybe she's going to have her a cup of tea, or whatever she has. Everything gets charted. Okay. I got to make sure that I keep a strict eye on her. And then I'm going to give her high iron foods. Yeah. Yeah, because she could be anemic. And now that she had all this blood loss, she'll be even worse. I get to get some lab work on her. I would do an H&H on this lady too, and see what her, or see, like a CBC, complete blood count. That would give you a great picture of everything. Okay, so Janelle remains at risk for continuing postpartum hemorrhage. So on my assessments must be ongoing. So she must be monitored for increased temperature, because I'm worried about that, maybe corneal amnionitis. I'm worried about her tachycardia, because don't forget she had blood loss, infection. If an infection does develop, she'll need antibiotics. And we're going to continue the oxytocin. And we might give her another dose of Hemorrhage. Okay. So safety concerns for this patient, falls. She's at risk for falls related to postpartum hemorrhage or excessive blood loss. That's a good one. Let's see, chest pain. Yeah. She's at risk for that. Shortness of breath, because those are symptoms of blood loss and they must be reported. Gonna be careful when she's handling the infant, because I want to make sure she's not dizzy. A lot of times dizziness goes along with blood loss, excessive blood loss. And she has to be very careful with the baby, because I don't want her, that's a safety issue with the baby and handling the baby. Okay. Now, don't forget, she could be in pain. Don't forget, you're giving her oxytocin. You're giving her Hemabate. So those are prostaglandins that cause the uterus to contract. Is she not having severe afterbirth pains? Yes, she is. So I would be also assessing pain level. And then I would encourage her to breastfeed, because don't forget, breastfeeding causes a release of endogenous oxytocin, which is beneficial to uterine contractions. That's why I love, every time I have a delivery, I always put the baby to breast right away, make sure she latches on real good, because it makes that release of endogenous oxytocin. Okay. Her own oxytocin. And then I just want to make sure she eats properly. So make sure she gets a food rich in iron. And then I may have her on iron supplement. So what am I thinking? If I give her an iron supplement, she could get constipated. So then I would have to worry about maybe giving her stool softener. And I need to know if she gets constipated, because if she had an episiotomy, I don't want her to rip out her stitches and her episiotomy related to excessive pushing down to have a bad. Okay, now can you see how everything kind of is a little cascade of events that can occur? It gets a little complicated, And don't forget, you got to keep her comfortable. And, she just had a baby too, right? Okay. All right. So that's a case study on a patient experiencing a postpartum hemorrhage. So you can see how your discussion number 3 question should have been addressed. Okay. All right. Now I'm going to, we did complications. So I'm going to take this opportunity to talk about the term newborn. All right. So when I talk about the term newborn, there's some things that you need to probably be looking at when you're studying the term newborn. And so, one, do newborns experience pain? Yes, they do. Okay. In the chapter you're going to read on the term newborn, it goes over pain. Also, you want to know what happens with newborn reflexes. This is the big one when it comes to HESI. I've seen where they had gagging on HESI. That's a reflex that actually saves an infant's life. And so let me go ahead and share my screen at this time now. And I'm going to bring up this chapter here. And I'm going to go in right into reflexes, as you can see. And so, excuse me so much. Yeah. Okay. Okay, as you go into reflexes, and there's some reflexes, like I said, that keeps an infant alive. So you have blinking and sneezing. Here's the big one, gagging, sucking, and then grasping. Now, these are really important. So when your mommy is breastfeeding, what am I looking at? I'm looking to see how that baby sucks. Can I hear him swallowing? That's another one. And then gagging. Is he gagging? So I want to make sure that he has these reflexes so that they can actually help him. So if I ask you a question based on this, such as, the nurse is aware that a full-term infant is born with which reflexes? Now, this is one that says it's all that apply. So, would it be, and this comes right from this slide. So hold on just a moment. Okay, this comes right from the slide. Is it blinking, sneezing, gagging, sucking, or grasping? Well, it's all that apply. It's all of them. They're right here. These are all reflexes that babies are born with. And these are ones that actually keep them keep them alive. So is this a pretty important? Yeah, it is. It's pretty important. Okay, I would know that. All right. So we have some other reflexes, and these are called the Morrow, which is another term for that is called the startle reflex. And this is where you take the little bassinet in the hospital and you may hit the corner of a door or something, and all of a sudden the infant, he just goes like like this. He's startled. His hands go up, and he may have his fingers in a kind of a C formation. That's called a startle reflex. Rooting, anything that touches the cheek, anticipation of food, they're right there. It's called rooting. You hold a baby. Tell you, if you hold a baby like grandmas hold babies and they're just cuddling, and all of a sudden they're going what? They're going to root. They think, okay, you got some, you're holding me this way, you got some food. Okay. And then your next one is called a tonic neck. And it's a postural reflex that is sometimes assumed by sleeping infants. And your book has a really, really good picture of that. And then dancing. I know when I saw the nurse, I had my baby, and it's like, it looked like, my son was actually dancing. I go, oh, he's a genius. He's already dancing. And she says, sorry, Mom, those are called prancing movements of the legs. I go, okay. All right. I hope that made you laugh a little bit. All right. The head. Now, the head is quite big, and it may have some swelling of the soft tissues because the head, right, has the suture and it's kind of compressed, and it has that so that it can go through the process called molding. Okay, it has to fit through the pelvis, so it has to give as it comes down, and so that's called molding. You ever see those babies that were down, maybe down in the pelvis, and they've been down there for a while, and so basically they may have some swelling of the soft tissues of the scalp. It's called capus succedaneum, which crosses the suture line. So if you see, like in the back of the head, if you see in the back of the head, it's called capus succedaneum, and I have a picture here of the suture line. You see the suture line here? Okay, so this is the occipital bone right back here. So back in this area, the scalp is like, has a little swelling. This capus succedaneum, because of where it's located, it crosses the suture line. It crosses the suture line. Now, another problem coming down the pelvis would be a cephalhematoma. Now, if you look here, I'm demonstrating, so I'm like, I'm on the side of my head. So I'm demonstrating this to you and showing you, I'm drawing a circle, is because cephalhematoma is a blood clot that's under the scalp. Okay. And so it does not cross suture line because it's over here on the side. So the suture line are going through the middle, and then the cephalhematoma is on the side of the cranial bone. So again, does not cross suture line. So these are little examples that they could basically be on a HESI or on your exam number 3. Okay, all right. And then you have the fontanelles. And let me show you my little picture here. You have the fontanelle, and you can see where the fontanelles here. And then this one in the front, the frontal fontanelle is shaped like a diamond. It's quite large, quite large. And then the occipital fontanelle is in the back. And that it has like a little formation, like a crescent, so you can see the difference in them. Okay, now let's move on to the ears. Okay, now ears, they're small, but they're well developed. They got everything, and the babies can hear at birth. Okay, now maybe you're premature or you're really sick babies, unfortunately, they may not respond to sounds in the beginning. But normally, this is a normal term newborn that we're dealing with in this chapter, that they do hear. And we'll test every baby before they are discharged. We want to make sure everyone. And so how we can do it without even putting any kind of elaborate machine on their head or on their ears, mom talks to baby, or someone in the room makes a loud sound, and the baby will respond to those, difference in the activity or the sound. He'll kind of turn his head toward that movement. Yeah, that means they can hear. All right. And it's very important to know if babies are hearing. So that's why we want to do all screening tests. Okay, and then their eyes, they can see, what they see is they see like oh, like, abstract things. They see, they have to really like fixate on points of contrast. One thing that I thought was so interesting, tears are absent until maybe 3 months of age. Now, some people, babies may have it at one, but most of them are three. And then all babies are born with blue eyes. And then after a few months, they change. Okay. And what you want, babies can, what they want to see is the bright lights, they want quietness, but when you have those mobiles, you have like very colorful, because it's kind of stimulating to the baby to have those. I don't know if you had those when you had your babies, but they're pretty neat. Okay, now sleep. Babies sleep. I don't know, but my baby never slept. But anyway, sleep is important. They say they sleep about 15 to 20 hours per day, and they have phases of when they're asleep and when they wake up. So you have like the first reactive phase, so they're awake, and then you have your sleep. And then when we talked about these phases already, so this is kind of a repeat, and then you have the second reactive, and then they have the stability where they sleep for a while, and then they wake up. Now, babies will wake up and they're crying because they're hungry, and usually breastfeeding moms, they feed every 2 to 3 hours. Okay. Now, do babies feel pain? Yes, they do. They produce catecholamines and cortisol. So the heart rate and the respiratory rates can change, and their blood pressure increases, as so does blood glucose levels. And then if they're untreated, they can have long-term effects, because the brain is keeping those in their brain, those pain pathways and structures required for long-term memory. They're well developed by, guess what, 24 weeks gestation. All right, and then unrelieved pain causes an irritability, and of course, they can't do well. So what do we do for circumcision? We give little lidocaine gel on the penis before they do the circumcision. Years ago, they didn't. Years ago, they just went ahead and circumcised, and babies, were very upset afterwards. And so we have to realize, yes, they do have pain. Yes, babies do have pain. Now, these are your pain assessment tools. And I did put this in your concept for quiz number 5. So please look these up. You got the comfort pain assessment tool is a 7-point scale. So what you're looking at when you do a 7-point scale, well, is the baby alert? Is he calm? Does he have muscle tone, facial tension, heart rate? Remember, heart rate goes up if they're in pain. And then cries. Cries is your 10-point scale. And then they include like facial expression, cry movement of the arm and movement of the arms. Sometimes they're not, that you can't console them. So yeah, it's not good. Okay, so C stands for cry. R stands for what? Requiring oxygen. I for increase in vital signs, because remember we said that. E for expression on the face, and S for is a baby's sleeplessness. That means the baby's not going to sleep. And it's kind of a point scale from 0 to 2. I think that one is the easiest one to use, truthfully. And then you have the next one is FLACC. So you have the face, legs, activity, cry, and this baby now is inconsolable. I mean, you can't console this baby. Okay, so I would know those, okay, and it's on, like I said, on your concept for quiz number 5. And then you got the PIP, P-I-P-P, and that is your premature infant pain scale. And then you got your NIPS. I think it's kind of cute, but you can neonatal. So N is neonatal. Then you have infant, and then you have P for pain and S for scale. Okay, so yeah, let me give you a brain teaser. So which acronym is often used to assess a newborn's pain? Which one do you think? It would be number 4, right?
Number 4, FLAC.
Yes, absolutely. And that stands for face, legs, activity, cry, and babies, they're not consolable. Yeah, poor little thing. And you have to know the other ones. You know, SROM is spontaneous retromembranes, and AROM is artificial. And GBBS is probably group beta strep. Okay. All right. So nothing to do with what we were talking about. Okay. So that's sometimes quizzes, questions can be like that. Okay. You got that hint?
We hope.
Okay, good. Okay. How about conditioned responses? Okay. So as a response or a reflex is learned what? Over time. And these babies learn to, they cry when they're hungry and everything else. So emotions are particularly subject to this type of conditioning. So if I was to ask you, we were talking before you came on board here, the nurse is aware, talking about reflexes. So I want to make sure you get this. So the nurse is aware that a full-term infant is born with what reflexes? So we went back up here to reflexes. Let me go back up here. Here we go. And we got these reflexes I want you to know. So blinking, sneezing, gagging, sucking, and grasping. These are reflexes that keeps babies alive. So I want to make clear that you got that. You'll probably see that again. So if I was to ask you that question again, the nurse is aware that a full-term infant is born with which reflexes? What would you say? Blinking, sneezing, gagging, and sucking and grasping. Okay, got it? Now, you're probably thinking, how does that keep them alive? Well, blinking's for their eyes, right? To keep things out of their eyes, to make sure their eyes, nothing gets in their eyes. Sneezing, make sure they have what? An airway. Okay, so whatever fluid is up there, they can sneeze it out. Gagging's real important because if they swallow something, like they have a lot of amniotic fluid yet when they're just born, they can gag it out. They can bring it up. Sucking, they need for feeding, and then grasping, so they can protect them. These are things. These are you probably don't study that way about how these could affect the infant, but it does make sense. Okay, so respiratory. Remember I said a long time ago, the most hardest job for an infant to do is to what? To breathe. Okay, and the most critical period is in the first hour of life. Yeah, first hour of life. And then we always position what newborns on their back or their side. And the reason why we do that is so that it keeps their airway open. Yeah, that first breath, when you deliver a baby, and I heard the first cry. That was so wonderful to hear that baby cry, because I knew then that first breath helped expand those collapsed lungs. Okay. And then what do they have in the lungs, especially their term, thank goodness they have it, is surfactant. Okay. And when we get into preterm babies next week, they don't have that production of surfactant like these term babies do. And this is where you need the surfactant. But term babies have it. Because once that cord is clamped, that's what they say. Once the cord is clamped, baby's what? On his own. And the lungs then take on the functioning. Now their own lungs are the breathing oxygen and removing carbon dioxide. Okay, so they're on their own. That's when we say, okay, we're going to cut the cord, and baby, you're on your own. So we want to make sure that the airway of a baby is what? Open, patent. So we want correct positioning of the neonate. I said on his back or his side. Remember that now. Write that down. And then removing any mucus from the mouth and nose with a bulb syringe. And here I put a little picture of a nurse doing that. And you do the mouth first, suction the mouth first. And the reason why is to prevent inhalation and aspiration during, during this time that you're suctioning, because they could have what we call a gasping reflex. And so you doing that and they go, like that. And so it can happen, especially, you're starting to do the nasal. So we want to do the mouth first. And how I always told my students to remember, because it is always on tests, is the mouth is bigger than the nose. Okay. And so do the mouth first. Okay. I hope that helped. All right. We're going to move right along and we're going to talk about APGAR. Okay. And we talked about APGAR before, so I don't think I need to go too much into it, but remember, there's 5 objective signs that are measured. Yeah. And they're objective because we can quantify them. And so heart rate. So remember heart rate, if there's no heart rate, you give a 0. If you're below 100 beats per minute, you give a 1. And if it's 100 beats or greater, you give a 2. Now, respirations, if not breathing, which is not a good sign, it's nothing, 0. If the baby tries to, and has like a weak cry, you give it a 1. If it has a strong cry, you give it a 2. Makes sense. Muscle tone. Okay, if I have a baby that comes out and he's real flaccid or limp, he's just kind of, like we call it a wet dish towel, then you give it a 0. You got nothing. But if he has something, like even a little bit of flexion, you give it a 1. And if the baby is well flexed, you give it a 2. Now, reflex irritability, if there's no response, he gives a 0. It has minimal response, he gets a 1. And we can call that minimal response like a grimace. Okay. Now, it has a prompt response, which is a good cry, is a 2. That's called reflex irritability. So a grimace is 1. You got something, but you don't have a lot, but you got something. And then he has a good cry, like I always told you, I like those first cries, then you get a 2. Now color. Now color, if you get is 0, if you're blue or pale. Now I've seen it on quizzes and I've seen it on tests where they give you a description and you have to figure up what the APGAR score is. So that's why I'm going over this. The color, and you give it a 0 if this baby's blue or pale. If the baby has a body that's pink, but his hands and his feet are blue, that's called acrocyanosis, and that's okay. You give it a 1. And then if you got baby who's completely pink, his little hands and feet are pink, and the little trunk of his body is pink, then he gets a 2. Usually about if we do the APGARs at 1 and 5 minutes. So usually at 5 minutes, the baby's color is more pinkish. Okay. I'm gonna may go down here. Let's see, we got here. We already talked about that. One thing I want you to know and make note to is if a baby has sternal, the sternum is retracting. That's never good. That means that he's having problems with respiration. He can't breathe because his little sternum, you'll actually see it on a baby, it actually retracts. And you just see the sternum go down deep and he's retracting it in because he's trying to breathe. That's never good. You need to report that. Okay. All righty. All right. Another problem we have with newborns is providing warmth. Babies are born with the inability, they're not able, like an unstable heat regulating system. So we talked about acrocyanosis, the hands and feet being blue, and we said that's okay. But the reason why they are is because in the peripheral circulation, the blood's not getting out there yet. Okay, so it's sluggish. But you warm him up. you know, when a baby comes out, they're wet. So I want to get a nice warm blanket. It's called a receiving blanket, and we keep them in the warmers. And we give a nice warm blanket. We dry them off. We take that blanket, put it in the laundry right next there, and then we get a new blanket, another blanket, and keep them warm. And that's when you see them really get pink very nicely. Okay, so we're going to provide warmth, and I tell you, the delivery rooms can be really cold. They can be cold. So that's why I put my the radiant warmer on in my delivery room. I put it on before that baby's even born. I want to have it ready. And that radiant warmer will put a lot of heat in that room because, again, cold babies don't do well. And I do not want to cold stress this infant. Okay. Now, this slide just shows you about obtaining temperature and pulse rate and respirations. What I want you to take note to is the bottom part where it says the nursery report. Those are really important to know. And I always told all my students, know the normal vital signs of an infant. If you know the normal signs of an infant, you'll be fine. So if you have a temperature elevation of greater than 99.8 or less than 97 because that baby's cold, you've got to report it. If you have a pulse rate of greater than 160, okay, that's tachycardia. That's not good. Lower than 110 would be bradycardia, and that's not good. Then respirations greater than 60, baby's is in trouble. Baby's not being able to breathe. Lower than 30, that's really now, he may be limp, he may have no reflux whatsoever. He has now his respirations are less than 30. And then if you hear grunting, it's like a real noisy respiration. It's like, and you're pulling, you know, you can feel that pulling in the throat. That's not good. And then another one is nasal flaring, or remember I just said the chest retracts. Not good. So make sure that you guys know that. And I told you, if you know the norm, you know this. Okay, let's go on. Again, maintaining body temperature in newborn is really, really important. Okay, and this picture is in your book. It really goes through very nicely. Let's go on to musculoskeletal system. Now, skeleton, yeah, their babies are pretty flexible, especially if you look at that that tonic neck reflex. I don't know how they do it. I guess we did it too when we were babies, but they're able to put one arm up and one down and have the neck over here, and they're pretty flexible. But when they're born, the head and the neck muscles, they're the first ones that come under control. Yeah, always support. When you hold a baby, you always support the baby with his head and the buttocks. If you got a baby in the head in one hand and the buttocks in the other, you got that baby. All right. It won't go anywhere. Okay. Now, I put in here the average length. About 19 to 21 and a half inches. Okay. The average weight from 6 to really should be 8.8, because when you get to a 9-pound baby, but I see a lot of babies today weighing 9 pounds, but those fall into that large baby, that macrosomic baby. Okay. Remember something too. I know Hesse, I think, had a question like this, that babies can lose about 5 to 10% of his birth weight. And you know what the reason for that is? Babies live in the amniotic fluid, right? Okay. And so they take in a lot of extra fluid. And when they're born, they try to squeeze. When they come down the vagina, the pathway, they try to squeeze out as much fluid they can. And then you can see babies coming out. You see like the fluid coming out of their nose and stuff when they're delivering. Well, that's because they have a lot of fluid in them. So in the first couple of days after birth, you know, their body is trying to adjust and get rid of a lot of that fluid. So that's where that extra fluid is. and mom's hormones that kept that moisture there. Okay, let's go to the kidneys. The kidneys are not fully developed at birth, but what I want you to know is it's important for the nurse to note the first void. We got to make sure that this baby, before he goes home, is putting out wet diapers. Okay, so it's really important. So at the hospital on postpartum units, we have a checklist, and on there it has about feedings, and it has about voiding, and it has about having a bowel movement. We got to make sure that all these things have now kicked in. So normally in a day, the baby should have at least 6 wet diapers per day. That's normal. Now, how, with breastfeeding moms know they get enough, baby's getting enough fluid, and breast milk is what baby's diapers, what he puts out. And that's about 6 to 8 diapers. Okay. Now, on the little baby boys, their testes descend into the scrotum before birth. And then what you want to know is the urethral opening should be on the tip of the penis. Sometimes if the tip is not in the middle and is over to the side, that's not normal. So right now we're talking about normal babies. And then he might have a white cheesy substance, which is found under the foreskin. So you want to just take that foreskin and clean underneath it. And then circumcision. Now, circumcision is up to the parents if they want to have the baby circumcised or not. That's their own decision. Okay. And we can, it's not up to us. But mom says, well, what are the benefits? Well, they have fewer UTIs. Can have fewer STIs. And studies have shown where there's some decreased risk of penile cancer. Now, what are some disadvantages? Infection and hemorrhage. Remember, a baby is not born with clotting factors. So if you circumcise a baby before they're 7 days old, they can bleed more. That's why now a lot of hospitals don't circumcise these infants right after birth, is that they have them go to the pediatrician's office and they have them circumcised there. On the female, now I've seen this has been on a test question or HESI, where a female, well, they might be slightly swollen because mom's hormones. And then they may have this kind of a discharge from the vagina. And that's called pseudo-menstruation. Pseudo. They're not really menstruating, because don't forget that doesn't occur till later, but it's because mom's hormones. Remember, this baby was inside, so whatever mom has, it went right to baby. And her hormones, same thing. Is circulating in her bloodstream. It went right across the placenta into the baby. Okay, so we have to just let moms know, it's okay. It's okay. And then we always clean the vulva from the urethra to the anus to prevent fecal matter from entering the urinary. Because that, if it's done wrong, can lead to a UTI. Okay, we know that. All right. Now the skin. We want to always assess the skin turgor and the overall skin condition. Now, babies are born with a fine hair, langugo. Now, pretermers, like we're going to talk next week, have more langugo than a term baby. When you get to be term, those little hairs are now shed. They're now in the amniotic fluid. Okay, because they don't need them anymore. A post-term baby would have much less. Now, also, a baby's skin is covered with Vernex caseosa. Remember, those are nice cold, it looks like a cold cream. It's real thick. And what it is, it protects the skin from irritation. Babies are in a watery environment. Just like if you were in a pool for X amount of hours, what you come out looking like? You come out looking shriveled, all wrinkled. Well, think of this baby is in water, And if you didn't have any of this Vernex on this really thick cream called Vernex Caseosa, his skin would not be good. Okay, now jaundice is like a little yellowish tinge to the skin, and is caused by the rapid destruction of what? Too many red blood cells. Okay, now write this down. If jaundice occurs in the first 24 hours of life, is called pathological jaundice. Okay, if regular physiological jaundice happens after like 3 days of living. Okay, so again,
on the first 24-hour call.
Yeah, jaundice that appears in the first day of life, the first 24 hours, is not normal. Not. We got to think. What you got to think is called pathological jaundice. And then I've got to start thinking about the what? The liver. What's going on with the liver? So what we would do on that kind of baby is when we do some liver enzymes. Okay. Because what's happening is in a baby, the liver is immature in a newborn. So, the baby has blood cells running through his system. Okay. And so if he has too much of red blood cells, he gets an excess of, and the liver can't break down the bilirubin in those red blood cells. So he gets an increased bilirubin, and that's what causes the jaundice. Okay. I'm going to go right into the GI system. Okay, so normal functioning of the GI system begins shortly right after birth. You have meconium. Meconium is your first stool, and it's a mixture of amniotic fluid and intestinal gland secretions. Meconium. It can be sticky, greenish black, thick, and passed from 8 to 24 hours of birth. Now, some babies have that meconium in utero. And we don't want them to, but sometimes they're under some type of distress. And so we have to take extra care when they're delivered to make sure that we suction these babies out. So the stool and the color and the consistency does change over time. And it's all according to what the baby's eating. Now, breastfed babies have, let me show you a picture. Breastfed babies have a real grainy looking yellow. Okay, really nice. Okay, and it actually smells better than a formula baby. Because formula babies, there's a lot of extra fat and everything in the formula, and babies can't break down all these extra additives because their stomachs are not can't do it yet. So it's better to breastfeed. And here's just a picture, and this comes right from your textbook of a meconium, and you can see it. It's like thick as tar, folks. It's really bad. And then you can see it change as the baby gets a little older. Okay, so whatever the baby's eating is what's going to come out. All right. Now babies can get constipated. Oh, and it's so bad when a baby gets constipated because they get so uncomfortable, and we don't want them to get that, so we make sure that we get enough feedings in to keep their peristalsis going. All right, and this is a little bit different, in a baby. Now, remember, babies can only take in about 3 ounces. That's about 90 mLs. All right, so that's not much. So that's why we have to feed these babies every 2 to 3 hours, especially breastfeeding, because breastfeeding don't have as much fat as a formula baby. So therefore, they digest the breast milk a lot quicker than your formula babies. All right, and then vitamins, if they're breastfeeding, usually we don't have to add too many more vitamins, but the baby may get some what we call polylysol. but you know, that's up to the pediatrician when you take them in and how the baby's doing. Um, and hiccups are normal. Yeah, poor little guys. You birth the infant and then you offer some warm water may help. Yeah, but they do have hiccups. All right. We want to prevent infection. So this is where it gets me when I see a lot of babies that are born, say, in December. Okay. And mom is going out Christmas shopping. Okay. And she takes the baby to the malls. Okay, they're around a lot of people. They can, they can get sick real easily because their immune system is immature, all right, at birth. So the most they have is some passive immunity from mom, but only for like 30 days, but that's not much. They get really sick. Now, another problem is the umbilical cord stump. That's a primary site of infection, and that's why we want to tell mom how to clean the stump so that it has to be kept clean. And of course, hand washing is the utmost on anything. All right. Now, this is your immunoglobulins. You probably remember this from your science classes, IgG. It does cross the placenta, and this is what provides the newborn with passive immunity from mom. And it's only good for the first couple months of birth, and it doesn't last longer than 3 months. So I know people love to have, their family over when a newborn comes home, but make sure that whoever's in your home is not sick. So this is why it's called passive immunity. All right. And then you have IgM, which is another immune globulin. That's immune globulin M, and that's produced by the newborn. And that's an elevated level of IgM. It just suggests you have a serious infection. Not good. And then you have IgA. IgA is produced after neonatal period, so about a month. And then it's contained in breast milk. That's why we want mothers to breastfeed. They get so many good antibodies and colostrum. I know this, I don't know if this was on your quiz, but it's on exam 3, I think. It's about colostrum. I just gave you something there. Okay. So, and then you have discharge planning. Okay. So remember, we start discharging planning for both mom and baby right on a mission, okay? And so we have to make sure that mothers know how to do basic care, okay? That means cord care, circumcision care, feeding, and changing diapers, okay? The baby's having enough wet diapers, at least 6 wet diapers a day, to know that he's urinating okay. He has a meconium stool, or now he's breastfeeding and now he's got more yellowish stool. You got to teach mom how to do all this. And then safety measures, proper position for sleeping, right? We don't put a baby on his stomach. No. Can aspirate that way. You put him on his back or his side. And then babies will go for a pediatrician for his immunizations, okay? And we'll probably give him, remember we're going to do the eye ointment that we talked about already, vitamin K, probably a hepatitis B injection. And so you get a consent for all of them, but they get them before they leave. Return appointments. We want to make sure that they make their pediatrician appointment because they got to take these babies in for their well baby care. Because a baby could be doing okay in the hospital, but then get home and mom's overwhelmed and maybe she's not taking care of the baby like she should and she got no help. Baby's not eating, baby's not gaining weight. You got problems. Okay. And then you want to use proper use of car seat. I tell you, no, they don't go home unless they have a car seat. And when we take moms down, we look to make sure they have a car seat. And you can get car seats free too. You can go to the fire department and get them there. Okay. Home care. Babies have to eat every 2 to 3 hours. Now, some moms say, well, my baby didn't wake up. Well, wake the baby up. Babies have to eat because remember, they only can take in like 3 ounces. right? At each feeding. That's not very much. So they have to eat several times during the day. And like I said, breastfeeding, the breast has is lighter, and so the baby is able to digest this breast milk easy, and it goes through their system, and so they would be hungry in the 3 hours. Okay, and then make sure you have a good safe environment for the baby, and make sure for clothing, because of their skin being so tender, you want to make sure that the material is soft and washable, and make sure that you give good skin care, and make sure that the baby is getting baths. And we do demonstrate that before they leave the hospital. Okay, I'm going to stop sharing, and I do have a case study on a newborn. And let me see, I may have, let me see how, about some questions. So let's see. Let's go over circumcision, because you might have this on a test. Okay, so if I was to ask you, which intervention would be included in the nursing care of a newly circumcised infant? So that means what interventions are there? Well, select all that apply. So if I ask you, one, do you wash the penis with warm water? Yes, right? Okay. You wipe with alcohol swab. I don't think so. Wouldn't that hurt? Okay. Gently remove the yellow crust formation. You do not remove that. No, so that's an X. Apply diaper loosely. Yes, you do. You don't want to put too tight on this is a newly circumcised infant. And dress it with a simple bandage. No. Okay, so which one was the best? Was wash the penis with warm water. Yep. And apply diaper loosely. Yeah. Yeah. You're not going to use any alcohol wipe on that penis. That poor little boy. I mean, I'll give you a good kick. And then you always leave that yellow crust. Sometimes they form a yellow crust. That's okay. That's like a scab. Don't remove that. Don't remove it. It'll fall off when it's done. Okay. So we talked about reflexes. Let's see. This is about thermoregulation, I believe. So let's read this question. The nurse reminds the new parents that newborns must be protected from environments that are too cold or too hot. Because of which aspect of the newborn's physiology? All right. So we're going to look at the answers. So it's a select all that apply. So they have very little subcutaneous fat. Well, we know that. Low metabolic rates. That doesn't have much to do with that. Ineffective sweat glands. Well, we know they don't sweat, right? And then small fluid reserve. I don't know. Okay. Well, let's see. And low red blood cell counts. What do you think? Well, we know very little subcutaneous fat. Yeah, newborns have very little subcutaneous fat, which offers little insulation against the cold. Well, didn't we say newborns don't have sweat glands? They have ineffective sweat glands. Don't we need that to kind of, if we get too hot, to cool ourselves down? So that would affect the thermoregulation. Okay, you got it? So if we don't have sweat glands to cool ourselves down, we would overheat, would we not? Yes. So because these newborns, I've seen where a woman in Florida, because I live in Florida, put a big blanket and all kinds of clothes on their newborns, and it's 90 degrees out. No, they're overcooking them. So it's like, no, don't do that to your baby, because the baby doesn't have a way to cool himself down. he doesn't have sweat glands. So that would go there. Ineffective sweat glands. Okay. All right. Let's see. Let's see. This is kind of fun to do for a little bit. All right. How about number? Let's see. Let me see. Yeah. The nurse knows that a post-term infant may experience which potential problems? Select all that apply. All right. Could a baby have seizures? Could he have asphyxia? Could he have paralysis? Hope not. Visual defects or polycythemia. So this is a post-term. So I'll help you with this because I think we go over this next week. So they can have seizures, they can have asphyxia, and they can have polycythemia. Okay. You'll know that for next week now. You'll be all prepared. Okay. Let me see. I'll save some of those for next week because that's on preterm babies. All righty. I think I have real quick. I have a case study. Let's see if I can find it around here, guys. Oh yes, normal newborn. I just happen to have a case study. You know, you get bored or anything. We got this case study. I put another case study for you to see on Canvas under announcements. So just kind of see it, and it'll be another case study also. And I went over the case study today before you came on. So when you look at the recording of this, you'll see that case study. It'll help you to answer that case study. Okay. All right. Then you know what I was looking for on the discussion number 3. All right, so we're just going to talk about this real fast about this is a baby that's admitted to the transitional nursery where the nurse will complete the physical assessment and she observes for physiological changes in infant's transition from intrauterine to extrauterine. When that baby is born, okay, he comes out into the world, is called extrauterine life. Extra, EXTRAUTERINE. Remember, when he's inside mommy, it's called intrauterine. So now he's extrauterine life. And, you know, we went through the phases of reactivity. Remember that? So like he has the initial phase of reactivity. He's like, it lasts from 30 to 60 minutes. Remember, he's awake and he's in the labor room with mom, or the delivery room with mom. And he's being breastfed by mom, and all the parents are there, and you know the grandparents may be there. Okay, and then he goes to sleep. Yeah, his little sleep time, and then he wakes up, and that sleep can go. It's all according to what book you're looking at, but sometimes from 4 to 6 hours, but usually it's a couple hours, and then they're taken back out from the transitional nursery to mom's room. Now, then they go through another second period of reactivity. All right. So, what care is specific to the first period of reactivity? So that remember that first period of reactivity I talked about in the labor room, the delivery room? Okay. So what's the nurse going to do after the baby's born? Put it that way. Well, she's going to do the APGAR score, is she not? Yeah. So we're going to assess and monitor the heart rate and breathing pattern and respirations and his color. Yeah, we're going to keep a close eye on all that for the first hour, okay? So we're going to do the 1 minute APGAR and the 5 minutes. Keep the baby nice and warm and facilitate the mother and infant interaction by having new parents hold their infant. Remember how mom holds it, how she talks to the baby, how she has the baby in face with her. What's going on? What's the dynamics going on in the delivery room? And then a lot of times we talked about putting that eye ointment in the baby's eyes because don't forget we have to, because we don't want baby to suffer from any gonorrhea in the eyes because that causes blindness. But babies during that first hour bonding, you don't have to put that eye ointment in right away. Not right away. What you can do is just delay it a little bit and let the baby actually try to what? Look at mommy, okay? Without having this eye ointment. If you ever put eye cream in your eyes, you would know what I'm talking about because once you put that eye cream in, you can't see. And so we like that to be done though before that baby's taken out. And don't forget ID bracelets. Don't ever let that baby leave that operating room or delivery room without having the bracelets on them. Baby has 2 wrists and ankle, and he has the security. Okay, very important. Do not to ever leave that out. Okay, and then he goes through the sleep phase and the second reactive phase that can occur in the nursery. So what kind of assessment now do you think goes on in that nursery? Well, we're going to look for choking. Remember, baby has a lot of amniotic fluid and a lot of mucus, and they can choke easily. So we want to make sure. That's why I said that reflex, that gagging reflex, was a reflex that would save their life. Now, I know for the past 5 years, gagging reflex has been on the HESI exam. There is no doubt about it. They always like to put it on. And you always want to teach the parents how to use the bulb syringe. Okay? You know, the right technique of squeezing and then releasing. Okay? And remember, what do we suction first? The mouth. Right. And then the nose.
The nose.
Okay.
Mouth and nose.
Remember, that's just the nose. Okay. All right. Gotta have some fun anyway. And then
Yeah,
observe for periods of apnea. I mean, sometimes these babies, they're exhausted by the time they come out and they go, oh, I don't want to breathe. I didn't have to breathe in utero. Why I gotta breathe now? Because we cut the cord. They're on their own. So sometimes you have to stimulate them to wake them up to breathe. Okay. And then you want to make sure that they can swallow. For years, nurses gave the first feeding in the nursery. And the reason why we gave the first feeding is we wanted to observe the ability to swallow without choking or vomiting. And then we're also going to monitor their temperature. I can't take a baby out to mom in the mother-baby unit, okay, without that baby being warm, okay, and his ability to maintain his temperature. You're always going to monitor his vital signs, his heart rate and respirations. I already weighed him in the delivery room. Okay. So we also, in the delivery room, we also weigh and measure. And real simple to measure. And so we do that. And then we're going to test blood glucose. Okay. A lot of babies are prone to hypoglycemia, especially the macrosomic babies. So write that down, especially the macrosomic babies. Hypoglycemia. Okay. Now, we also can do a little hematocrit to make sure these babies are not anemic. What baby would I be worried about anemia at birth? What babies would that be? That would be a baby born to an Rh negative mom. Okay. Now, mom has real GAM, thank goodness, but I want to make sure this baby is not anemic at birth. That's the baby I would definitely want to have it do a hematocrit on. And let's see, we talked about the eyes, talked about the vitamin K. And we, a lot of times we give hepatitis B vaccine. And then we're also assessing his reflexes, so we talked about. And we're going to try everything. It's a lot of work in that nursery. And then bathe the baby to remove any vaginal amniotic fluid. You know, he may have some vernix. Now, years ago, we tried to get the vernix off, but now we wash the baby, clean the baby, but if the vernix is still there a little bit, we leave it, you know. And then we don't ever want to rub his skin to remove any of that vernix. No, it does disappear and gets absorbed into the skin. And then again, we want to make note to baby voiding, because the baby needs to void, right? Okay, and because the kidneys are immature. And so just kind of think of this. Think of this. The infant, okay, he's a small little person, is he not? Okay. But he just was born. So a lot of the organs that have been formed, that have been developing for the last 9 months, okay, they're not all the way developed. So a lot of times they come out and they have immature kidneys, immature liver. But as they grow and they're fed, then they come around. They all develop nicely, or they mature, I should say. They're developed. They're there, but they need to what? Get, you know, mature. Okay, and then we're gonna make sure we always maintain airways. Always. Babies again have a lot of mucus. Okay, and you want to make sure that you keep them warm. That's called thermoregulation. Okay. Again, their little bodies are immature and they're not able to keep their own body temperature. That's why they depend upon you and me to keep them warm. Okay. And then breastfeeding. I always promote breastfeeding, but if they want to bottle feed, of course, we want to make sure that moms know when they go home how to mix the powder if they use the powder, because the other free mix is more expensive than the powder form. And then circumcision care, make sure that they know how to clean the baby and also observe for any kind of bleeding. Now, a PKU test is a test that we do, and all babies have to have it. Is a test for phenolphthalein. Is a protein that some people, some children, some infants can't break down. And if they can't break it down, then it builds up in their system and it can cause mental retardation. So it's a mandated test. All infants are tested for PKU, and you can only test them. Now, listen up, everybody. You can only test them after about 2 to 3 days after birth. It cannot be done the first 24 hours. Reason why is because they have to ingest enough protein in their body to see if they can break down that protein. So the test is called a Guthrie test. Guthrie. It's a Guthrie test. And that test is done just about when the baby's going to leave the hospital. Now, the mom goes home in the first 24 hours. We can't do it, but they are mandated to bring that baby back to the hospital to have that PKU test. And when you tell a parent, well, we want to make sure that this baby doesn't have this metabolism defect. And if he does, then he could it can affect the brain. And so when you tell somebody that, they usually very compliant, that they'll be back to the hospital to have that done. Okay. Now that's really important what I just said. So do you understand that? You got that pretty clear? Okay, hope so. All right. And then we have the RH incompatibility problem and jaundice. Now, we talked about RH incompatibility occurs when the mom is RH negative and the infant is RH positive. Okay. And so they may need like a Coombs test, and a positive Coombs test means that the infant may need extra fluids, needs to spend some times under the belly light because of jaundice. Okay? All right. So if I asked you, what is the significance of the Coombs test, you would tell me that a positive Coombs test means that the mother has formed antibodies that coat and damage the infant's RBCs. So as the infant's RBCs rupture, the bilirubin rises and is deposited in infant's brain, and therefore causes mental retardation. Yeah, and we'll probably go over that a little bit more next week, but I just want to put that in as we study this case study. Okay. So I would actually want you to know that. Okay. Okay. All right. So if you have a baby, think about it. If you have a baby that's lethargic and not feeding well, that's how you know a baby's sick. You know a baby is sick when he doesn't feed well. What would be your next action be in that nursery? Okay, you always want to check the baby's blood glucose level. Could be that he's hypoglycemic. Okay? And then you can call the doctor. All righty. So that was a little case study on a normal newborn and what goes on in the different periods of reactivity. Now, let me see if I can find an interesting question that we went over some things already with. Let's see. Give me a few seconds here. Oh, I like this one. Okay. All right. So you have this baby. You're the nurse, and you have this baby who's 12 hours after delivery. Okay. So which assessment findings will the nurse report to the doctor? Okay. So apparently these findings are not going to be normal. Select all that apply. So what would you report nasal flaring? The nasal flaring means up to a doctor. Would that be a bad sign? Yes. A respiratory rate greater than 60 beats per minute. Would that be a bad sign? Yes. Because it's greater than 60. Okay. Chest retraction. Remember I talked about that chest retractions? Not good. Bad sign. And then he has an apical heart rate of 100. That's slow, right? Yes. So that'd be a bad sign. So that's why I told you to know the normal vital signs of an infant so that you can answer this type of question. So the newborn's pulse, should be from 110 to 160, just like in utero. Remember that in utero? 110 to 160. Now, the average blood pressure at birth is about 80/46. And the baby's respirations are 30 to 60 beats per minute. Now, I can tell you in your HESI book, and I hope that you are using your HESI book to, after you read your textbook, use it as a little short version. It goes over, and in your HESI book, it has a really good table of normal vital signs for an infant. It does. Okay. If the question was this nurse or the postpartum mother, she expresses concern that her breastfeeding infant stool is yellow. What would be an appropriate response to the patient's concerns? Well, first of all, she's breastfeeding, right? And what's the color of the stool for a breastfeeding mom? Yellow. It's okay, Mom. It's normal. It's normal for breastfeeding babies to have, remember I said it's yellow and grainy. Okay. All right. So be sure you read over the term newborn. And I have all those slides for you to look at everything. All right. If I have a baby that has an elevated bilirubin level, and we talked about that, how do you take care of a baby that has a elevated bilirubin? Remember, that's the case. So he's jaundiced, right? So you would use phototherapy. You know, you put him on what we call the Billy lights. Okay. Now, you can put a baby out in Florida in the summer in the sun, and that would be very good because that's ultraviolet light. You have to put a baby under ultraviolet light for the ultraviolet light to break down the bilirubin. So that's called phototherapy. So make sure that when you're doing your reading, you take note to phototherapy, and you have to protect the baby's eyes from the ultraviolet light, just as you go to the beach. Okay. And you're sitting out on the beach, and don't you wear a hat, and don't you wear sunglasses? You can't look into that sun without sunglasses, right? Because the ultraviolet light will damage your eyes if you did. All right. So you got to have an eye covering for this baby. And when a baby's under phototherapy, we're going to give it lots of fluids, because that's how you want to break down the ultraviolet light on the baby's skin. Baby's naked. On the baby's skin breaks down the bilirubin, and when the baby urinates or he has a bowel movement, he gets rid of the bilirubin. So that's why you have to give fluids to this baby under phototherapy. Okay, I think I'm going to end there now. We did quite a bit today with a good review. And keep up the reading, please. Okay. And if you have any questions or concerns, please send me an inbox. I'm going to go ahead and stop the recording.